I will start the session now. Good morning. Good afternoon and good evening to all. This is the second series of our ACNS Haneda microvascular decompression forum, and this time we be co-host together with Renji Hospital, School of Medicine, Shanghai Jiao Tong University from Shanghai, China. With us to chair this session is Professor Yoko Kato, Professor of the Department of Neurosurgery, Deputy Director, Fujita Health University Bantane Hospital, Nagoya, Japan, and Professor Daijong, who is the Professor of the Graduate Supervisor, Renji Hospital, School of Medicine, Shanghai Jiao Tong University, Shanghai, China. And we have two prominent speakers for tonight. First is no other than Professor Fuminari Komatsu, who is an associate professor from the Department of Neurosurgery, Fujita Health University Bantane Hospital, Nagoya, Japan, who again will speak to us on endoscopic microvascular decompression, a new trend in the endoscopic keyhole surgery, followed by Professor Wang Yu, who is the associate professor at the Department of Neurosurgery, Renji Hospital, Shanghai Jiao Tong University School of Medicine, Shanghai, China, who will speak on full endoscopic microvascular decompression and our experience. And we have two prominent discussion for today. First is Professor Gleb Danilov, who is the head of the Laboratory of Biomedical Information and Artificial Intelligence of Research and Development, Budenko Neurosurgical Center, Moscow, Russia, and Dr. Zhu Jiangqi, who is a resident of the Department of Neurosurgery, Renji Hospital, Shanghai Jiao Tong University School of Medicine, Shanghai, China. With that, before we start the first lecture, may I call upon Professor Kato to give her welcome speech, Professor?
Hi. So thank you very much for this. Is the second time of our initiative of the ACNS and Haneda Microvascular Decompression Forum. So my assistant, Professor Komatsu, he is very good at microvascular decompression with pure endoscopic surgery. And he maybe, I think, more than 200 per year so far. So very skillful, and maybe we finish in maybe one and a half hours. So maybe you will enjoy Komatsu Sensei presentation. Okay, so anyway, so another one is Professor Wan. Maybe we are very much looking forward to your lecture. Thank you very much.
Thank you to Professor Kato. I also would like to hear a short speech from Professor Daijong, who is also co-hosting this series. Professor, please.
Yeah, due to the COVID-19 and the adjustment of our hospital academic disciplines, our academic exchanges between China and Japan were interrupted. Today, I'm very glad that we have restarted off our academic exchanges and continue our friendship. So I hope that from now on, not only we will be able to hold the webinar like this, but also we will be able to continue holding our previous offline China, Japan cerebrovascular diseases forum. Today, I'm very glad to meet Professor Kato online. Thanks.
Thank you, Professor Daijong. So without wasting more time, it gives me a great honor to welcome Professor Komatsu to speak on endoscopic microvascular decompression, a new trend of endoscopic keyhole surgery. Let us welcome Professor Komatsu.
Thank you, Dr. Liu. Can you hear me?
Yes, Professor.
All right. Thank you. I'm Dr. Komatsu from Japan. I want to share my screen. Can you see my screen? All right. All right. So, let's start my presentation. I'm talking about the endoscopic microvascular decompression for trigeminal neuralgia and hemifacial spasm. I'm a member of the Bantane Hospital under the Professor Yoko Kato. Our hospital is located in the almost center of the Japan in Nagoya City. I studied the endoscopic anatomy previously, more than 10 years ago. My main work was endoscopic keyhole anatomy through the several keyhole. And also I have some experience in the clinical experience in India, 1.5 years. So I had a lot of endoscopic cases there in India. So let's talk about the endoscopic microvascular decompression. So successful microvascular decompression requires two elements: precise identification of neurovascular conflict and appropriate decompression. So endoscope provide a panoramic view to see the identification of the neurovascular conflict, and also the transposition technique is a desirable method for long-term outcome. I introduced our method. The patient is placed in the park bench position. Then after making a small incision, 1.5 centimeter retrosigmoid keyhole is created. Endoscope is fixed on the pneumatic holder, and the single shaft instrument are used for the manipulation. This is the photo during the operation. We used the 4K ICG endoscope system. These are equipment. Mainly the single shaft instrument are used. For the decompression, the two methods are known. The one is the interposition. The prosthesis is placed between the cranial nerve and the offending artery. Another one is transposition. The offending artery is completely separated from the cranial nerves. So we do the transposition technique and the endoscopy, and transpose the offending artery is fixed with fibrin glue only. This is suitable for endoscopic surgery. I showed some illustrative cases. The first case is a trigeminal neuralgia. The 3D image shows that trigeminal nerve is compressed by the SCA. The video is shown. After making a small incision, a keyhole is made, and then the scope is introduced. Now we can see the trigeminal nerve, and also the SCA is compressing the root entry zone of the trigeminal nerve. ICG is given. So the arachnoid around the trigeminal nerve is bluntly dissected, and SCA is exposed. The offending artery is mobilized little by little with dissection of the arachnoid, and then the SCA is attached on the dura with fibrin glue. So fixation is confirmed, and also the trigeminal nerve is separated from the petrosal vein. This is So pre and post surgical view show that excellent decompression to the cranial nerve. The second case is a similar case, but the petrosal vein restrict the visualization of the trigeminal nerve. Even such cases, endoscope provide a better view for us. So the SCA is similarly mobilized and attached on the dura with fibrin glue. After decompression, from the small space, we can see the trigeminal nerve and the surrounding structure very well. Another case is the case of the trigeminal neuralgia caused by the trigeminal cerebral artery. Trigeminal cerebral artery is a normal variant of the posterior fossa artery. The video is shown. Now we can see the trigeminal nerve, and trigeminal cerebral artery penetrate the trigeminal nerve near the Mecca cave. For this case, the SCA is initially separated from the trigeminal nerve and fixed on the tentorium again. And also the proximal side of the trigeminal cerebral artery is mobilized as much as possible, but it had the because it has the perforator, so no complete transposition was impossible, and the interposition was added. And finally, this part of the TCA is also mobilized and attached on the dura between two petrosal veins. So this is final view. The arteries are separated from the trigeminal nerve, and this is the final view. In our series, the such TCA cases was 3.4%. And next, show the cases of hemifacial spasm. The first case is the hemifacial spasm right side. The ICA is offending artery in this case. The video is shown. The incision is almost same. Keyhole. And then the endoscope is inserted. We can see the 7, 8, and the 9 cranial nerves. A 30-degree endoscope inserted. Then we can see the ICA running on the facial nerve. So this ICA is mobilized and attached on the dura with fibrin groove again. And now the indentation on the facial nerve is well recognized. All perforators are well preserved. This is final view. Post and pre and post surgical views show the excellent decompression in this case. Another case is the left side hemifacial spasm. It's caused by the ICA-PICA common trunk. ICA branch and the PICA branch from the common trunk compressing the left side facial nerve. The video is shown. Again, the small incision is made and the keyhole is created. We can see the 8 and the 9 cranial nerves, a 30-degree endoscope inserted. ICA and the PICA branches occupy the small space. So the ICA is mobilized from small space that we can see the facial nerve. So the ICA is attached on the dura with fibrin glue again. Attachment was created little by little. Now we can see the bifurcation of the ICA and the PICA. So this bifurcation was also attached on the dura. Finally, the PICA branch is also attached on the dura. So this is final view. The indentation on the facial nerve is well recognized, and all perforators are well preserved. These are pre and post surgical views. And also in cases of the hemifacial spasm, vertebral artery is well related. So again, I show the video. So after making a small keyhole, we can see 7 and 8 and 9 cranial nerves. Vertebral artery is running on the facial nerve. Even this vertebral artery, it's mobilized and attached on the dura with fibrin glue. it was attached on the dura enough. And then we can see the indentation on the facial nerve again. So pre and post-surgical views are shown, and the patient symptom well recovered after the operation. And this is another case, minor case. Also, the vertebral artery is involved. In the surgical view, the ICA, variant ICA, is attached on the dura. This is also normal variation. It's attached, connected to the subarachnoid fossa. So the ICA is partially separated and create a space, and 30-degree endoscope is again introduced. We can see the vertebral artery. So this vertebral artery is lifted. And also the pica branch is also visible. So this artery is again attached on the dura with fibrin groove. And the decompression to the facial nerve is well performed. So this is the final view. The ICA attached on the dura is also preserved. The ICG is given. The bloodstream is confirmed. This kind of the attached ICA is, it was 3.3% in our series. So far, we had more than 550 cases in last 4 years. Last year in 2024, we had approximately 200 endoscopic MVD cases. So in such cases, the surgical result, the classic trigeminal neuralgia was patient recovered in 19.5%. As for hemifacial spasm, the approximately 90% patient was recovered well. For the permanent complication, the in last year, the hearing impairment was happened. It happened 0.5% in one case. CSF leakage was not confirmed, and also the wound infection was 0.5%. The permanent complication rate of permanent complication is very low. For discussion, it is controversial, which is better in endoscopy and microscopy. Some literature shows that some advantages in endoscopic MVD compared to microscopic MVDs. For example, low recurrent rate, high detection of the offending artery. But other articles also say that surgical result was not significantly different between the endoscopy and the microscopy. From another viewpoint, Dr. Lee said that in group of the endoscopic microvascular decompression, the such cases show that less postoperative headache, meaning that less invasiveness of the endoscopic surgery. So I think it's still controversial to conclude a significant difference between the two groups. However, I think the endoscopy has significant difference regarding minimally invasiveness. So we need to investigate more such surgical results. Thank you for your attention. This is the end of my presentation. We will have we will start the Fujita Health University Haneda Clinic. It's opened in the Haneda Airport, the largest airport in Japan. We will start to accept the international patient. So if you have any patient, good candidate, please refer to us in the future. Thank you for your attention.
Thank you. Thank you to Professor Komatsu. Now we open for discussion. Probably I invite Professor Gleb Danilov to start first, Professor.
Thank you. Thank you so much, Professor. Bunseng, thank you, Professor Komatsu, for such a wonderful lecture, such a delicate surgery, very beautiful and very effective with the low percent of complications. Thank you so much. And I want to ask a question. What do you think about using exoscopes for that type of surgery? Is it prospective or not? And do you think that some robot assistance could be also useful for that kind of delicate surgery?
Thank you. Thank you, Professor, for the question. For the first question, I think the exoscope. I think that's in my opinion, but exoscope is almost same as a microscope. So from my viewpoint, nothing is different from the microscope. Probably the surgeon might be little comfortable, but the surgical result must be same. That's my opinion. And also, but as you say, the some robotics, it's not still not made so at this moment, but in the future, probably it would be replaced our manual hands. So I think it would be, it might be better. It might have a good result in the future. Thank you.
Thank you. Thank you so much.
Okay, so let us hear from Dr. Zhu Su Tiang Chi. Is he here?
Yes, thank you. Thank you, Professor. And I'd like also to thank Professor Komatsu to have presented such an inspiring talk about the EMVD surgeries. My question is, I noticed that in your presentation, you prefer to use a pneumomotor holder. But in our center, we tend to use a first assistant as the endoscopy holder. So have you ever tried your assistant as the endoscopy holder? And is there any difference? And the second question is that I noticed that some of the cases you used a 0 degree straightforward telescope, and in other cases you used a 30 degree forward oblique telescope. Have you ever tried a 45 degree oblique telescope to do the surgery? Thank you.
Thank you. Thank you very much for a good question. For the first your question, I think it's about the endoscopic holder. Here in Japan, we have the company, Mitaka company. It provide a good endoscopic holder. So that's why the most of us Japanese uses the endoscopic holder instead of the assistant holding. So that's why I don't have such a experience. The assistant hold the endoscope, so for in the wide space, it might be comfortable, but I prefer to use the a small keyhole. So that's why in that case I think the holding by assistant might be difficult. So I'm not sure. So that might be also controversial. I don't have enough experience. And also you said the second question, the degree of the endoscope, 0, 30, and 45. In our institute, only have 0 and 30-degree endoscope. And also another one is the variable endoscope. You may know that the variable endoscope is provided by the Karl Stoltz company. The angle of the endoscope can be changed during the operation. It has the handle switch, small switch. I think it can be changed from 20 to 100, approximately 100. Sometimes I use, but the quality of image is quite low, so very limited cases I use. Thank you.
Thank you.
There is a question from Dr. Bing. Could you on your video?
Yeah, can you hear me?
Yes,
Yeah.
yes, Professor.
Yeah. Very nice to meet you again, Professor Komatsu.
Thank you.
Yeah, very nice PPT. Yeah, my question is about the trigeminal neuralgia. Yeah, in some cases, the patient before operation, the symptom is very typical. The facial pain is very typical, but during the operation, we found no offending artery. All the artery compress the nerve slightly. So in these cases, I found the result is always not good. Could you please tell me when did you come across these kind of cases, and what did you do for these cases? Thank you.
Thank you. Such cases, the patient had trigeminal neuralgia, but the arterial compression is not seen. That case is called idiopathic trigeminal neuralgia. We
That's
also
right.
have a lot of cases, and the operation is done. And for such cases, the internal neurolysis, meaning that making small incision on the trigeminal nerve. That
Did
is
you
performed. Yes.
Did you cut off some of the nerve?
No.
Cut
Yes.
off
Yes.
the sensory root?
Yeah. Sensory root.
Only
Sensory
yes,
root.
that's right. Thank you.
Sometimes I think that I showed that surgical result today. It's but not it's effective in short time, but in the long time, I think the effectiveness is gradually decrease. So that's still controversial. But anyway, the internal neurolysis is effective.
Yeah. Thank you very much.
Thank you.
Just Komatsu-sensei, how you can cut the fifth nerve?
It's
2-3 parts?
also the many surgeons say many methods, but in my case is I just make 3 or 4 incisions on the trigeminal nerves along the fiber of the trigeminal nerve. So I mean the longitudinal direction the incision is made.
Now we open to the audience. Is there any question from the audience? Maybe I start with one question, Professor Komatsu. In terms of difficulty between offending artery and vein, do you think that which one consume more time for transposition? Which one is more difficult? And would the result different between offending vein or offending artery? Another question, Professor. Do you think that current instrument are good enough for pure endoscopic microvascular decompression, or you think that more innovation is needed to have more type of equipment? Thank you, Professor.
Thank you. For the first question, I think the artery and the vein, So the vein is also controversial. I'm not sure it is offending vessel or not. Always I wonder. In my opinion, in such cases, I think that it looks the vein is the offending vessel, but I think that case is the idiopathic case of the trigeminal neuralgia, as I said before. So that's why I usually transpose or decompress the vein. Instead, I make a internal neurolysis, make an incision. That's effective. I think that, in my opinion, that case is the idiopathic case of the trigeminal neuralgia. And the second question from you, I think that, of course, the instruments must be developed much more. I think that, Dr. Graves said that robotics, our instrument still doesn't have any joint, so it can only use the one direction. So that's why the robotics would be changed our surgery much more. But it's still need a time, I think.
Thank you, Professor. Barry, you want to ask question?
Yeah, I have a question. Professor Komatsu, thanks for your
Thank you.
comprehensive presentation. I have a question. In case of idiopathic cases, radiology, there is radiology shows no findings, but when you open, what findings you commonly find in idiopathic cases?
Thank you. It's also interesting question. Most of the cases, it doesn't have any arterial compression. But in limited cases, I think the less than 10%, we sometimes encounter the trigeminal cerebral artery. I saw the one case today. The diameter of the trigeminal cerebral artery is very small. So that's why it's very difficult to identify such arteries preoperatively. So sometimes, very rare, but it might be possible. So that's why I think going to surgery, we don't hesitate to go surgery, even the idiopathic cases.
Thank you.
Thank you. So we close the first section. Thank you,
We
Professor.
can ask Dr. Dai.
Oh, Dr. Dai, you want any question from you, Dr. Dai?
My question have been replied at previously. Thanks.
Thank you, Dr. Dai. Thanks again to Professor Komatsu. Hopefully, there will become company come forward to develop new instrument together with Komatsu, and we have Komatsu name after the instrument. So let us move on to the next speaker. It gives me a great honor to invite Professor Wang Yu to speak on full endoscopic microvascular decompression, our experience. Professor, please.
Excuse me, can you see the screen now?
Yes.
Oh, okay. Good evening, professors. My name is Tianqi Xu. On behalf of Professor Yu Wang, I will present the following slides. The topic today is fully endoscopic microvascular decompression. Our experience. It is a teamwork made by our skull-based neurosurgical team at Renji Hospital, Shanghai Jiao Tong University School of Medicine. And since the first microvascular decompression procedure performed by Professor Peter Janetta in 1966 in UCLA, MVD has become the standard treatment to cure cranial nerve disease, such as hemifacial spasm, trigeminal neuralgia, and glossopharyngeal neuralgia. And with the wide application of neuroendoscopy in the new century, endoscopy assisted microscopic MVD, and later on, fully endoscopic MVD have been introduced and widely adopted. And we think that there are several advantages of fully endoscopic, fully EMVD, endoscopic MVD. Is the first one is that it is the micro-invasiveness. This is due to the less arachnoid membrane manipulation required with the assistance of the view of the endoscope. And the second is that wide visual field, enabling us to perform a thorough whole lens in the 360-degree inspection of the cranial nerve, especially for the patients with trigeminal neuralgia. And the third is that the clarity arising from the ultra-close observation with the endoscope. And in China, Professor Xiaojie Lu and Professor Qing Wang from Jiangnan University Medical Center are the pioneers of EMVD in China, and they perform and published research articles of EMVD since 2010. And in our center, we adopt EMVD as a first-line surgical treatment for hemifacial spasm and trigeminal neuralgia since 2019. And there have been 300 cases out of 500 consecutive microvascular decompression cases were performed in an endoscopic manner. And during this 6-year period, we have concluded some of our experiences. And the first one is that we always use assistant holder. Instead of using a mechanical commercial pneumomotor endoscopic holder, in our center, the assistant of the surgery always held the endoscope so that the dynamic and the live adjustment of the visual field is feasible. And the second one is that we use different forward oblique telescopes, including 30 degrees and 45 degrees telescopes as a supplement to the straightforward telescope, which is 0 degree. And that can help us to get a different visual angle and better visions. And the last one is we always take advantage of the strength of the neural endoscope to achieve ultra close observation so that some details of the vessels and nerves and compression sites can be seen. And now we will present some of the cases to elucidate these points. The first case is a patient with left side hemifacial spasm. And excuse me. It is a patient with a left side hemifacial spasm, and we perform the procedure in a fully endoscopic manner, including the preparation process of the cutting into the subarachnoid spaces. This is we are cutting the arachnoid membranes in the lateral cerebellar system to expose the REZ zone. And we use a Hopkins straightforward telescope 0 degree in this process. But as we can see, the vision is somehow limited. And to get better vision, we changed a forward oblique telescope, which is 45 degrees. And in 45-degree telescope, we can see that the facial nerve was exposed in a clearer manner and the difference of the visions. The different vision, and we can see the offending vessel or corporate vessel and the compression site on the facial nerve. And we can see the difference of the vision in 0 degree and 45-degree telescope. The difference was evident. And after the compression mark on the facial nerve was spotted, we use a polymer pad, a Teflon pad, and we place it in position to decompress the nerve. Let's have a look at another case. This is a patient with a right hemifacial spasm, and a forward oblique telescope, which is 45 degree, was also used in this case. First, we still use the 0 degree straightforward telescope to to dissect, and we can see the this is the vestibular cochlear nerve, the 8th cranial nerve, and but the facial nerve was somehow hidden, and after changing into the 45-degree telescope, excuse me. We can see the facial nerve clearly, and the blockage of the vision in the 0-degree was solved in the 45-degree telescope, and it is with a satisfied clarity, and we can see the compression site very clearly, and the Teflon pad was then placed in the compression site, and the patient have a good outcome. And the third case is a patient with right trigeminal neuralgia. First, arachnoid membrane in the lateral cerebellomedullary system was also dissected, and through a straightforward 0-degree telescope, compression of the trigeminal nerve by corporate vessel can be seen evidently. And after that, ultra-close observation was adopted to verify whether there is a compression of the trigeminal nerve near the Makos cave by superior cerebellar artery. And unlike MVD for HFS, where the compression site of the facial nerve by the corporate vessel is constant, and in cases of the MVD for trigeminal neuralgia, in our opinion, a thorough whole length and 360-degree inspection of the vessel compression is highly warranted to achieve better surgical outcomes. And as is shown in the operating video, no vessel compression was seen near the Makos cave, and Teflon pad was placed at the compression site to decompress the nerve. And in this following case, on the contrary, superior cerebellar artery loop compression on trigeminal nerve was discovered at a deep cryptic location near Makos cave through ultra-close observation. We can see that we are dissecting the offending vessels from the nerve, and in our opinion, there are a few blind spots in the attempt to thoroughly inspect the trigeminal nerve through microscopic view, but in this scenario, EMVD using endoscopic to perform microvascular decompression demonstrate unique advantages due to the ultra-close observation of the endoscope. And after finding the corporate vessel, we use Teflon pad to place at the compression site. And this is a case we perform using a STORS 4K high solution endoscope system, and we can even see the nerve tracts through ultra close observation. And apart from 4K endoscope, we also start to apply a 3-dimensional endoscopy in EMVD procedures. 3D endoscope provide a sense of stereo perception, which can optimize the micromanipulation process of the nerves and vessels to give a better sense of stereo perception. And this is us still dissecting the membranes. And there are some angles which we cannot see from the microscopic view. And also a Teflon pad was placed in the compression site. In general, endoscopic microvascular decompression plays an increasingly important role in treating cranial nerve diseases. And in our center, through these three strategies, we achieve satisfying outcomes for our patients. Thank you for your attention. Thank you.
Thank you, Professor Dr. Wu. Now we open for questions. Maybe we can again call Dr. Gleb Danilov to ask the first question.
Yeah, thank you. Thank you so much. Thank you, Dr. Xu, for your very interesting talk. And I paid attention that you're probably really focused on technological side of that surgery, because you were talking about endoscopes and different angles. So the first question is, are you involved in some development of new types of endoscope or that kind of technique in China, or are you interested in participation? And the second question is that's something related to my favorite theme, to artificial intelligence. Do you think that using a computer vision to recognize anatomic landmarks intraoperatively can be helpful in that type of surgery, at least to those who start that type of surgery? Do you think that type of technology would give some benefit to newcomers? Thank you.
Thank you, Professor Danilov, for your question. For the first questions, whether we have participated in the development of the instrument. Actually, I think the bar is a little bit high to develop such surgical instruments, because the ethics now in China are still very high as well in recent years. But we do have some innovations of our instruments. For example, on the endonasal endoscopy, we do the approach when we get into the nasal cavity. We use our Foley catheter to extend the meatus of the nasal cavity. So just some small innovations, but to invent a whole new instrument, it can be a little bit difficult. But we have a very high demand while we do the surgery, because sometimes we can see the area we want to operate, but the current instrument cannot allow us to get to that place. And this is the first question, the answer to your first question. And the second one, undeniably, I think artificial intelligence have a great progress in every field. And I think the visual recognition of the AI, it can provide very assistant during intraoperative. But my concern is that there is still some probability that the AI may make some wrong calls, and the consequence is just too heavy for us to take. Maybe we need to do some clinical trials before put that into clinical settings, right? Thank you.
Thank you so much. Thank you for your thoughts. Thanks.
Maybe I will ask two questions, Professor Zhu. First, you have mentioned that you always use supplement 45 degree, 30 degree instead of just 0 degree. Do you follow certain algorithm? Start from 0, 30, 45, or you interchangeable? Because we need to program our brain in terms of hand movement. For different degree, you need to move differently. So is there any protocol? No, you must start with 0, then 30 degree. And I saw you have an instrument that have a dissector in 45 degree. Is it a malleable dissector, or is it a fixed 45-degree instrument that you use? My second question, Professor, how much prediction that you use in pre-op imaging? Because in Professor Komatsu surgery, he have a lot of pre-operative imaging simulation to tell him best position to put in a burr hole direction, and to identify likelihood the direction that he need to go for the offending vessel. How much does that help in your surgery? Is there anything that you want to tell us? Thank you, Professor.
Thank you, Professor, for your question. For the first question, whether there is a difference of hand movement in the different angle of the endoscope. Yes, actually, since I am giving the speech on behalf of Professor Wang Yu, who is my mentor, and I'm his protege, and I always held the endoscope. And I think that there are some differences in holding different telescope with different degrees. But I think there's a learning curve. After maybe 3 times, 4 times, you can get the tricks. Yes, and for your second question, our instruments they are not tailored to different kinds of degrees of the telescope. They are the same instrument. We just change our view angle and the vision angle. And for your last question, yes, I'm impressed by Professor Komatsu's simulation pre-operatively, and it really can the pre-surgical planning on the burr hole really can just mini invasively finding the offending vessel. But for us, we just use the normal incision, normal burr hole. But I think the angle the telescope can just make it possible to see the offending vessels in different area. That is our point, using different degrees of the telescope to find the different position offending vessels. Thank you for your question.
Thank you. Maybe now we open for the audiences if there's any question. Meanwhile, we can get some comment from Professor Dai Jung, Professor.
Yeah, I wanted to ask one question. I see the 3D endoscope in the MVD surgery. So I wanted to know, are there more advantages for the 3D endoscopic? I see the glass is very cool.
Thank you, Professor Dai. Actually, there have been two main, actually 3 main new directions for the endoscope development. One is 3D, one is 4K, and the other is ICG. And there have been some devices. They have both a 3D and 4K. And for the endoscope system we have used, we noticed that 3D endoscope, they can provide better stereo perception, so that we can have more direct and we can get some more direct information from the depths of the anatomic structures. And but some in 3D endoscopic systems, the resolution of the screen and the camera is lower than the 4K. That is, but now we have both 4K and 3D endoscope. I think that is the developing direction. Thank you.
Thank you.
Dr. Petra.
Hello, Dr. Chu. Thank you for the presentation. I want to ask about your experience being the assistant holding the endoscope. Do you have some tips and tricks for us? How best to hold the endoscope so the operator does not see it moving? Do you use a hand support or is there a special trick? Thank you.
Thank you, Petra, for your question. And during some operation with very long hours, and it can be suffering to hold the endoscope for a long time, for hours. At first, we use a hand. We use some. I lay my hand on some objects. But after a while, I think that there is a trick. The trick is you need to just place your extremity just as close as your torso, so that so that it won't be that tiring. Yes.
Yeah,
Thank you, Dr. Chu.
I have experience in Osaka. They use the endoscope holder to rest your hand. So you may use that for that reason. Okay, Dr. Ben, your question?
Yes, and thank you so much for your lectures. I want to ask, because I also heard that in China, they have the Chinese-made endoscopic holder. So my first question is about, do you have any information or experience with the Chinese endoscopic holder? My second question is about like when you have the assistant usually hold the endoscope, but how about would you in some time do the assistant also put the instruments inside, so you have free instrument inside your port? So yes, that's my question.
For the first questions, yes, there has been some Chinese-made endoscope holder, and I think the pneumomotor and some centers in China they use the pneumomotor holders. And the reasons we don't use the pneumomotor hand holders is because you need to adjust the direction every time you want to move it, and it cannot be move live and live movement, especially in some critical moment in the surgery. And the second concern is that some of the pneumomotor holders, they have some, you know, when you decide to set it into a location, and after you release your hand, it will move just a little bit difference. That is the difference of the actual position and the position you want it to be. That is the reason that in our center, we always use assistant as the endoscope holder. And for your second question, excuse me, what can you repeat the second question?
I mean, sometimes do the assistant also need to assist the chief surgeon by putting one more instrument inside?
Yeah, and for that question is that we adopted a two-man and four-hand technique, right? And actually, in certain position, you can just hold endoscope using one of your hand and using the other hand to maybe to drill some water, or maybe to handle the suction. Yes, I think it is possible, and during my experience, it is possible.
I see. Thank you so much.
Thank you, Dr. Ben. Probably we hear some comment from Professor Yokokato. Professor?
So thank you very much, Dr. Chu. A nice presentation. So just I want to ask the methodology of the detach the vessel. You do only the prosthesis insertion, not transportation, or any the policy, your treatment way. Thank you.
Thank you. We there have been times that we don't have any polymer Teflon pads, so we do the other technique. But after we have the Teflon pads, we find it reliable to use the pad to separate the offending vessel and the cranial nerve, and we sometimes use some glue, some bio glue to prevent the Teflon pad from dislocation. Thank you.
Okay, thank you. Maybe Komatsu-sensei, can you tell him how to transposition our method, please?
As I said, just as I separate the offending artery from the cranial nerve and touch the dura with fibrin glue, it's also easy. It's easy, but I'm not sure. It depends on the countries the fibrin glue is available or not. Sometimes I heard fibrin glue is not easily used in some countries, so that's my afraid.
But so far, the result is very good, I think. So maybe Dr. Xu, you can try.
Thank you.
We don't use the Teflon for transposition. Thank you very much. Best regard to Dr. Wan. Thank you.
Thank you.
Thank you for a great lecture. Hopefully, we see more collaboration between Renji Hospital and Fujita. And I think it's time for us to close this session and this webinar session. So I would like to again invite Professor Dai Jung to give a closing remark. Professor.
Today, I'm very glad I can attend this forum, and I learn more from two speakers. So I hope we can continue the forum like this, and I also hope we can meet offline and continue the forum previously. Thanks.
Thank you, Professor Dai Jung. And Professor Kokato, closing remark.
Oh, I think Dr. Dai, thank you very much for your nice final words. And maybe in future we can meet in physical.
Yeah. Meet offline.
Yes, yes.
Yeah.
Maybe the country by country or the province to province. I think some of the different ways to the techniques, but I think we can collaborate. We can get advantage
your help
from
and support. Yeah,
Thank you so much.
thanks.
Thank you, Dai.
Yeah, thanks.
Thank you, Komatsu-sensei. Also, thank you very much, Dr. Liu. Daniel, thank you.
Thank you so much.
So thanks to all our chair speakers and the discussion. So till we meet again in our next webinar, probably in April. Again, is usually the second week of the Thursday. This is bye-bye from all of us. Thank you, Professor. Good night.
Okay, bye-bye. Thank you very much. Bye-bye.
Thank you.
Thank you. Bye-bye. Thank you.
Thank you.
Bye.
Bye.